All right, well, we'll just move along here. So we'll go through the post-op management. You guys will probably ask, what do we do? And we sort of touch bases on that. We fix aneurysms. And this here again depicts what an aneurysm is. This is an image of a normal aorta, or what a normal aorta should look like. And this is an image of an aneurysmal aorta. These are the two types of repairs that we just basically touched upon: the open repair, the endovascular repair. What are the other things that we treat? Well, the aorta can develop aneurysms, but also it can develop what's called occlusive disease. So if this is the aorta, and this is plaque in the iliac arteries restricting blood flow to the legs, we bypass that. And that will be called aortoiliac occlusive disease. The same problem that can occur here in the aorta, the occlusion, can occur other places in the body, in the leg, in the arteries behind the knee, and that's called femoral popliteal or infrapopliteal disease. So we sort of touched on what an aneurysm is, enlargement of the aorta, and this is one of those cool CT imaging modalities we just talked about. The different ways of diagnosing it, once again, the ultrasound, this is the ultrasound probe with a wand. Sound waves come across this, come back and give us this image, which is, can we dim the lights just maybe a little bit? Give us this image of this aneurysm, which is this out-pocketing here. Good. The CT scan, as we talked about, can be done in multiple images, sections depicting this large aneurysm here, and this is it looking at it as if the person was sideways and you're looking directly at them. That's what this image here is. So aneurysms are the sort of the what do you want to call it? The slang term is AAA. That's, you know, in our society. So AAA, and that's what we'll use this, because aneurysm is a mouthful. So we fix aneurysms when they're greater than 5 centimeters. Other indications to fix them are when patients develop back or belly pain. If we think about this image here, this is the lumbar body here. This is the aorta, so it sits right on the vertebral bodies in the lumbar area. So if there's blood here, or if this thing starts to expand, what happens here is it stresses there, pushes against there. That can even erode into the bone, and that's why patients get back pain. Or the other thing is when it pushes against what we call the abdominal viscera. Think about it here. These are the small intestines all here, pushing against that. As it gets larger, it can cause pain. So that's why we talk about back, or when my patients come in and I follow them, I ask them all the time, do you have back or belly pain? You know, and they'll tell me. Other indications for repair, if the aneurysm grows, the accepted rate of growth for an aneurysm that we follow every year is 1/2 centimeter of growth of size is allowed per year. So if they come in to see me this year and the aneurysm is 4 centimeters, I'll have them come back in a year, we'll check another ultrasound. If it's 4.7 centimeters, even though it's not reached 5 centimeters, at that point, by the criteria that's set down by our national society, the Society for Vascular Surgery, that's an indication to repair it. So greater than 1/2 centimeter of growth within 1 year. The treatment options, you guys saw this slide before, but we'll just hit it real quickly. On this side, this is the the open repair, where there's a graft that's actually sewn in by hand, made out of Dacron, and then we take the old aortic wall and sew it over the graft to protect it. The other option, like I said, 80% are done this way now, what's called the stent graft, or the endovascular repair, where an incision is made in each groin, the graft is passed up and deployed, and it fixes to the aortic wall. There's little prongs here, and we'll go through this. We have the device rep left us a graft we'll deploy, and you can see what it looks like. It fixes to the aortic wall. And patients love this because, one, you don't feel like you're getting hit by a truck. The other thing, they come in, they have their procedure, they go home the next day. So it's pretty good. This was a video of how the graft deploys. I apologize. I got up this morning, it's about 5:30 or 6. My wife probably was ready to kick me out of the room. Making so much noise, but for whatever reason, and I don't have any IT people here, I cannot get this. I mean, we can try, but I cannot get it to, I could not get the video to play, watch it play. Ah, okay. So just watch this here.
Abdominal aortic aneurysm is a potentially life-threatening condition characterized by degenerative changes in the wall of the abdominal aorta that lead to progressive dilatation and possible rupture if the condition is untreated. The traditional approach to abdominal aortic aneurysm repair has been an open surgical procedure. Endovascular repair, using an endovascular stent graft, is a more recently developed approach. In this procedure, a guide wire is introduced into the abdominal aorta through a femoral artery. This is followed by the sheathed main body of the stent graft, which is positioned with the use of fluoroscopy. The body of the stent graft, composed of a non-permeable polyester material supported by a self-expanding flexible metal frame, is partially deployed, with the undeployed upper portion of the device positioned immediately below the renal arteries. A second guide wire is introduced through the contralateral iliac artery into the open lumen of the contralateral limb of the stent graft. The top cap is removed, deploying the suprarenal stent and anchoring the stent graft to the vessel wall. The contralateral limb component of the stent graft is then introduced and deployed with overlap sufficient to prevent leakage around the junction of the main body of the device and the proximal end of the limb, and so that the distal end of the contralateral limb is located superiorly to the internal iliac artery. The ipsilateral limb of the stent graft is deployed in similar fashion. A balloon is then introduced and used to expand all graft-to-vessel and graft-to-graft junctions in the proximal to distal direction to ensure a tight seal. Finally, the sheaths and guide wires are removed and the femoral arteries repaired. Aortic blood subsequently flows through the stent graft. Endovascular abdominal aortic aneurysm repair is intended to relieve further pressure on the aneurysm and reduce the risk of further dilatation or rupture.
Well, usually what I was waiting for, once the graft is deployed, we put balloons up there to fix the graft and make sure that it is firmly attached to the aortic wall and the iliac arteries. In answer to your question, how do we size it? Based on the CT scan, we can take, that's the other thing. Based on the CT scan, we can get the size of it. So we measure the CT scan. This area up here is called the neck. This is the renal arteries. This is where the aneurysm begins. That area is called the neck. In order to do the endovascular repair, we need to have a neck of at least 1 centimeter. And we take the diameter of the neck. So let's say, for instance, the neck of the aorta is 20 millimeters or 2 centimeters. Then we take 10% oversizing. And so we'd say we use about a 24 millimeter device based on the findings on the CT scan. So that's how we size it. And we do the same thing down in the iliac arteries. We get to size them because what the beauty of the CT scan is we can place calipers in there, go from wall to wall, sort of like we do upstairs to measure an artery when we're placing a stent. We get the diameter, and then we can do our sizing based on that. And if it gets really complicated and we're not sure now with more modern things, there's what's called, as you guys are aware of, intravascular ultrasound. So we put an ultrasound probe up into the aorta here. It gives us the diameter of the aorta, the aortic wall, the iliac arteries. Also, in people that have contrast allergies or renal failure, we can use it to identify our renal arteries to limit the amount of contrast that they get. So now, that's an endovascular aneurysm repair. Sort of the trash term for that is EVAR, E-V-A-R, which stands for endovascular aneurysm repair. So you'll probably never hear me say that word again. But So now, this is where you guys come into play. What are the complications of EVARs? One, just like anything I do or any other surgery, probably, myocardial infarction is probably at the top of the list. And a lot of these patients want to go cardiac clearance, stress test. Some of them want to go CAS even prior to the procedure. Aortic rupture. So you haven't seen it, but you'll see it just down the road in the talk. We have to fix that graft to the aortic wall. What is the risk of that balloon can overinflate and rupture the aorta, and that will have you filling your pants up quick. Groin hematomas, we make incisions in the groin sometimes we even do what we call percutaneously without making an incision, but when that device comes out or the sheath comes out, the artery can bleed, so there's groin hematoma. Arterial ischemia, means lack of blood flow. So a lot of ways, mechanisms, injury to the artery at the time of surgery can cause disruption. Plaque can break off, go down, embolize, shut off the blood flow to the foot. So arterial ischemia of the feet. And for those of you who work in the ICU, know I always come by and check everybody at night before I leave, almost invariably. Just for whatever I do, this is a complication. Cerebral vascular accident, or CVA, stroke. We pass the wires up. You have to really monitor where the wire is, because that wire can end up in the brain if you're not keeping an eye on it and break off plaque. It can puncture the carotid artery, one of the intracranial arteries, intracranial bleeding or embolization of debris up there. Atheromas and emboli to the feet. We just talked about the things breaking off. What's called intestinal ischemia, loss of blood flow to the colon. We'll see how that works later on another side. And then what's called spinal cord ischemia. Someone has an aneurysm repair, they wake up, they can't move their legs. That will all be outlined right here. So we talked about the graft being advanced up. This is all the steps to deployment, which we just saw in the video. This debris on the inside of the artery, that's atheromatous debris. When we pull this device out, reperfuse the foot, this is what can result. Our slang, we call that trash foot, meaning that bits and pieces of the artery wall or the aorta break on off, embolize, and shut off the circulation to the toe. Spinal cord ischemia. So we saw the image of the relationship of the aorta to the vertebral bodies. This better outlines it. We have this line. This is like looking at the patient sideways. This is the aorta coming from the heart, coming down to the pelvis. These are little spinal arteries that come off the aorta that give blood supply to the spine. Well, when we do aortic surgery, those are sacrificed. So then the spinal cord becomes ischemic. Sometimes it's benign, sometimes patients end up completely paralyzed, but this is a problem. And what happens here with the endografts is when we place this, we reline this aorta, we're taking away that blood flow. Now, most of the time, 98% of the time, the patients are able to reperfuse their spinal cord from other means. So this here just is a better idea of how this works. I don't know why the slide came out better here, but here's the aorta, the artery to the spine. It's called the artery of Dankowitz. And you can see this EVAR graft here covering those arteries. Now, they're going to be certain, unfortunately, if a person has an aneurysm one place, like an aorta here, the chances of having one up in the chest is going to be higher than just someone that walks in off the street. And so now, as this specialty advances and gets more sophisticated, the endografts we do here, I don't know that we'll ever do this here, but we do this in the chest, putting what's called TEVAR, thoracic endovascular aneurysm repair, where the graft is put here. Well, the problem with this here that you're probably seeing, if you cover these spinal arteries here, and then you cover these spinal arteries here, these people are really prone for spinal cord ischemia, which has happened here. They were covered here, then the patient later had an EVAR graft here. So that's almost completely taken away all the spinal cord blood flow. The next one we talked about is intestinal ischemia, which means loss of blood flow to the GI tract. Most commonly it's the colon, and this is the reason. This is the aorta, and this is the inferior mesenteric artery. Now, a lot of times this does not mean a lot because that artery will be thrombosed and shut down. But when it isn't, when we put the endografts in, we take away that blood flow. When we do an open repair, we ligate it. So if the colon loses the blood supply and it's not well collateralized, meaning that the blood flow is coming from another source, this here is called the watershed area. That area is very prone to what we call infarction. And unfortunately, this is what it looks like. And this here is not a good feeling. So, and the way this is diagnosed, the treatment sometimes is just observation, hydrating the patient, anticoagulating them, and a lot of them will do well, but a lot of them will go on to completely infarct the colon and require colostomy. And so the way this is diagnosed is endoscopy, looking up, looking at the mucosa of the colon, and then doing serial endoscopies. We're not just doing this yet, but hopefully we will be, but this is one of the things in the post-operative orders that used to be, nursing sort of gotten away from it. If the patients have bowel movements within 48 hours, that's a concern. Now that's probably not a big concern because most of them are done endovascularized in their home in 48 hours. Okay, let's go back. We talked about aortic rupture. As you can see, to fix this EVAR graft, we place this big balloon up here. We inflate it to get the prongs on that graft to stick to the side of the wall. Well, sometimes if you get a little bit too overzealous with your inflation, you take your post-op angiogram and you see all this extravasation of blood, which is not a very good feeling. The treatment is to put the balloon back up, reinflate it, and hope that that seals, but this is a major problem, and that's the other reason. And the other thing is this can be delayed. In other words, the patient can complete the procedure, they can be back in the ICU, or even now they go to the floor. And they all of a sudden start complaining of back pain. Well, maybe the problem is that they had a little tear there that was okay concealed, and as the blood pressure got a little bit higher, this got bigger or extended it to what we call a complete dissection or disruption to this here. So that's another concern. And the signs and symptoms are back pain, increased abdominal girth, unexplained hypotension, and tachycardia. So now from the post-op order standpoint on these patients, what we do is one, just like as excellent nurses as you all are, patient assessment, including Doppler, weight, neuro assessment, making sure that they can move their feet, and also that they can move everything upstairs and not stroke. Looking at the wound to make sure that there's not hematoma, assess for back, chest, or abdominal pain. They all go on telemetry. The standard labs for our patients are CBC, Chem7. We'll get PT, PTT, and always check troponins for 24 hours to look for myocardial infarction. We always monitor urine output. We use antihypertensives. The first line of antihypertensives for us are beta blockers unless they're bradycardic. Then I'll use a prezoline or hydralazine. And then the second line, in the older days, we used a lot of niprite. Now we tend to use more nicardipine, which is a calcium channel blocker. Hemodynamic drugs, we use dopamine for hypotension, sometimes Levophed, also dobutamine. Antibiotics, patients that have prosthetic grafts placement, we give them one preoperative dose of antibiotics. We give one post-op dose of antibiotics. A lot of them will plus or minus have an ART line. It depends on how sick the patient is preoperatively. Some of them may have CVC, central venous catheters. Most of them won't. Most patients will undergo aortic graft duplex the following day, and if everything looks okay, they'll go home. And that's done several reasons. One, we want to have a baseline to see what the graft looks like. The other thing, if we see what's called the endovascular leak, which we talked about earlier, it's not a big thing, but you want to know about it to make sure it's not increasing. So again, we talked about the endo leak before. There's 4 types, type 1, 2, 3, and 4. Type 1 is a problem with the fixation of the device to the arterial wall. Type 2 is the patient's own arteries continuing to fill the sac, which are the lumbar arteries, which give blood supply to the spine, and the inferior mesenteric artery. Type 3 was the graft disruption. Type 4 was the porosity. In other words, it's like, I don't know, water coming through a sweater or a shirt or something that it just diffuses through. So now in the vascular leak, we talked about that earlier. Basically, they do the ultrasound, they get color images, and they can see the blood in the actual sac. CT scan really defines it a lot better, but we talked about the radiation dose. The CT scan, this is the graft repair here. This is the contrast within the aneurysm sac. And that's a fairly good size endoleak. Okay, carotid arteries, we treat that. And what is carotid disease and how do we define arterial disease in the carotid? Well, if an artery has greater than 75% diameter, that is considered hemodynamically significant. In other words, that's enough narrowing to create a resistance or a diminished blood flow to that particular organ, the brain, the leg, the kidney, even in the heart. So this here sort of gives us an idea of what that looks like. This is a normal artery. This is when plaque starts to build up. This is an artery that has a significant stenosis here. And when that flow reduction becomes enough, it results in thrombus formation. Now, hopefully the patients will get to us before this occurs. If the thrombus occurs in the leg, it's not a big deal. But when that thrombus develops, and this happens in the carotid, it can be very bad and devastating stroke. So this is why the patients I see, that have 50% or greater, I will get yearly carotid scans to follow that. This is the carotid artery. This is the jaw here. The carotid comes up, it bifurcates. There's the internal carotid artery, which goes up and gives the blood flow to the brain. This is a normal artery. This is what carotid disease looks like. It functions in 2 ways. One is we can see that there's a narrowing in the artery. Everybody sees that. The other thing, however, within that narrowing, it develops little ulcerations. Or I tell patients, think about the crater on the moon where you have a little dip on the surface. The problem there is, in that little, we call that an ulcer crater, clot can form in that, and this can be the mechanism of how patients have TIAs. Bits and pieces of this break off, go up to the brain, and this is what the brain's showing us here, form a little clot. The patient comes in and says, you know, doc, I couldn't move my right arm for about 20 seconds, and then it all came back. Well, that's called a TIA, transit ischemic attack. And transit meaning that it returns back to normal. So, and this is the mechanism of that. Or the other thing is that flow, that narrowing can be so severe that if there's any drop in the patient's blood pressure, maybe heart rate or whatever, they don't perfuse the brain and they have this again. So this is the mechanism of how patients have TIAs. Now this slide here further depicts what we were just talking about, but let's talk about the symptoms of carotid disease. First of all, anybody that's worked with me, I sort of do it fast, but I like to cover all bases. I will ask the patient, have you had any temporary loss of eyesight in either eye? And it's called amaurosis fugax, temporary blindness, that's the Latin word. So what happens is the patient's watching TV, reading the newspaper or whatever, all of a sudden they either go blind in the eye or either the patient comes in and says, you know, doc, I was watching the football game and it's like somebody pulled the shade down over my eye. And it went away on its own. That is classic amaurosis fugax. And what happens here is that 1 or 2 mechanisms. One, there's a reduction in flow based on cardiac output or whatever. Or the other thing, there may be a little, you guys will all see the little ulcerations there, break off, goes up the carotid. There's what's called the ophthalmic artery right here. It goes into there. It shuts off the blood flow to the eye. Other things, speech difficulty. Everyone remembers the brain thing, the right brain, left brain's speech center, so forth and so on. Well, the same thing can happen. Reduction of blood flow, or something breaks off and goes to the dominant hemisphere. They can't speak, you know. I was riding with my wife and we're talking, and she said I couldn't get my words out, or I said the wrong thing. Well, that's a TIA, and it all resolves within time. And that's the problem here. Numbness or tingling of an extremity, the same thing. If it's the left brain, all of a sudden, I can't move my right arm. I can't move my left leg, or I go to get out of the bed and I fall because I couldn't control the leg. That again is a TIA, or complete paralysis of the extremity, which is called hemiparesis. Those are all signs of carotid disease. Now, something probably less specific will be a headache. For carotid stenosis or carotid disease, simple thing, physical exam, listen to the neck, auscultate it if you hear brewery, neurologic exam, making sure the cranial nerves work, strength is good in the upper lower extremity. And this is the one, probably none of us do it that often anymore, but it was sort of fun when we did do it, called fundoscopic exam, looking into the eye, looking into the fundus. And you see these little plaques of cholesterol, which if you see that little golden thing right there where it's pointing, that is the thing. It was perfected by a doctor from the Mayo Clinic, Robert Hollenhorst, who was an ophthalmologist who saw patients that had carotid disease. He was identifying they had these plaques he saw in the fundus that was basically breaking off in the carotid, going up to the eye, causing their symptoms. How do we diagnose it? We go back to the good old ultrasound, the carotid imaging. Dan the man, he picks all these up, you know. They'll scan them. We get these waveforms. We get an idea of what the blood flow is like, and then we also can get an image of what the artery looks like with all the ulceration and debris. We won't go into this a lot, but this process is called spectral analysis. It measures blood flow. And I tell patients the thing is, it gives me a number which is called the velocity. The worse the number, the worse the problem. So if we'll say 100, we'll say 80 to 100, so okay, velocity. So this one's one side is 80. But if the other side is like 500, that's a problem. And basically what that means is that to make it simplistic, for blood to get through this area, because the stenosis is so narrow, it has to develop a large amount of energy, which is the velocity, and that's what gives us this number. There's a lot of different thoughts. Some people will operate based on the duplex scan. I like to see some anatomy. There's several ways we can do angiograms. There's a carotid angiogram, putting the catheter in the artery, injecting the dye, or now what's called CT angiogram is becoming more popular. Well, this is both. This is a CT angiogram. This is a standard catheter-based carotid arteriogram. You can see this gives us a nice delineation of this narrow artery right here in the internal carotid artery. So there's two ways to treat carotid arteries. One is the placement of carotid stents, and we'll see if we can get the video to play. And the other is to next is carotid endarterectomy. Nice. Okay. So this is a depiction of a carotid stent. We place a wire up from the groin. Then what happens with what's called a protection device to catch debris. Then we sometimes will go in and balloon it to make it open enough to get a stent in. And once that's done, we take a stent up and we deploy the stent. Sometimes the stent doesn't open fully and we have to go in and balloon it again to open it more. You can see the little particles showering in there. Then we go in and we retrieve the protection device and take a picture, making sure that we haven't gooned the artery or anything, and that's it. So this here is a slide that just shows the carotid artery narrowing and how it looks post-stent placement. However, even though stents are nice, endarterectomy still probably remains the standard of care. Stents were initially, there was a criteria for someone to have a carotid stent. Long list of things. Patients that have had previous head and neck cancers, radiation to the neck, which was going to make surgery technically challenging. Patients that were considered too sick for an operation, what was called New York Heart Association stage 4 disease. Patients that had severe pulmonary disease, renal function. Someone that's had a carotid endarterectomy or some other neck surgery and the laryngeal nerve was injured on the other side. You don't want to take a chance of entering on the other side because then they have complete vocal cord paralysis. So now we're in the carotid endarterectomy. This is what the plaque looks like. The patient goes to sleep. There's an incision over the carotid artery. The artery is exposed. This plaque here, as you see, maybe with a little bit of thrombus there, this plaque is teased out and then the artery is then sewn up. So this is, when I do the endarterectomies, almost 99% of the time I use a little device called a shunt. It's a silastic tube, placed it this way towards the heart, this way towards the brain. That carries blood to the brain while I'm working. That way I don't have to feel stressed to move along, and I can take my time and do a good job. And then this is what the plaque looks like once it's out. And so you saw the previous slide of the endarterectomy. This is how I do most of mine. I saw in this patch, because supposedly most studies say that the patch decreases the incidence of recurrent stenosis. Okay, complications of carotid endarterectomies are stroke, myocardial infarction, cranial nerve injury, we already talked about that, the recurrent laryngeal nerve causing hoarseness. Also the hypoglossal nerve may be causing some difficulty with tongue movement. And then the facial nerve, the marginal mandibular branch of the facial nerve. Patients sometimes, well, their smile will look a little crooked, you know, from the retraction, or either the nerve may be injured. Neck hematomas are a big thing. We'll talk about that in just a second. Intracranial hemorrhage. Postoperatively, we check neuroexam, EKG, troponins, because there's about a 1%, 2% risk of myocardial infarction with carotid endarterectomies. Neuroexam, as we talked about, checking the tongue movement, checking the voice, make sure the smile is symmetrical. And we also check neck girth. That's an important thing. I can remember once in my career, I get a stat page to come to the ICU that there's a neck hematoma, and I asked her on the phone, how do you know? She said, I looked at it. Looking at a neck post-surgical is not going to give us any information, so these patients need neck girth measurement, and it's based on if you see an increase in the diameter of the neck, that's concerning. We've gone over this. So the labs we get CBC, EXTREMITY, PT, PTT, and this is going to be almost all our surgical patients. We check urine output. Hypertension is a big thing with carotid endarterectomy because it stimulates the carotid sinuses. So we really have to monitor them closely, and that's why they go to the ICU. The hemodynamic drugs are important. Also, bradycardia is another big one because of stimulation of the carotid body nerve. These people can get profoundly bradycardic. They all will get antibiotics because of the implantation of the patch. Most carotids have arterial lines. And then we also have to check for swallowing because of all the dissection, you can injure the nerve. And unfortunately, some patients may aspirate. So this is the mechanism. If you can see this, this is someone that's had a carotid. This is a neck hematoma. You can see that hematoma is pressing on that. This is the trachea, and this is the larynx. It presses on that, and I mean, they can get big to the point that you can't intubate them. They may have to have trachs. So those are things that have to be picked up fast. This slide here is just to show you the relationship of the nerves that are encountered during carotid endarterectomy. The branches of the vagus nerve sit right along the carotid artery. Here, this slide here shows us this. Who knows what nerve that is? Just out of curiosity. I'll buy pizza. So anyway, this is why we have to check the tongue This is the 12th cranial nerve, the hypoglossal nerve. It comes right across the internal carotid artery. And you know, we dissect it out, we retract it, we pull it. It really gets speed up during operation. So that's why we have to check the nerves.
Can you put a stent in the carotid? About what is the average length of time that it lasts, or does it?
The question is, what's the, and what you're asking, the term is patency. So the question is, what is the patency of carotid stents? Stents or the operation? Which one? Stents. The answer, no one really knows at this point. And the reason why is most of the carotid stents were done on patients that were really not healthy for surgery. The unfortunate thing is a lot of them might not have lived long enough to see what the patencies are. But now there are some reports that are saying, you know, 60 to 70%, which makes in 5 years, which however makes carotid endarterectomy much better, because the 10-year patency rate of a carotid endarterectomy is like 80%. So that means if you get your carotid artery cleaned out today, in 10 years, there's about an 80% chance that there won't be any recurrent stenosis. And it's not that high with our carotid stents. With the stent, the problem is there's going to be a lot of, just like stents that are placed anywhere else, there's a lot of what's called intimal hyperplasia, meaning that there's ingrowth of material into the stent that can cause recurrent narrowing. Okay, so next, lower extremity arterial disease. And there's two forms. There's occlusion, where the artery is blocked. That causes what's called claudication. And then there's, just like anywhere else of arteries, you can form aneurysms in the arteries in the leg, the popliteal and the femoral artery, which this is. Okay, symptoms of occlusive disease. That's called intermittent claudication. Claudication is a Latin word for pain. So you get intermittent pain with walking. So claudication is one, what's called rest pain. Excuse me, so rest pain will be defined as, I go to bed, if I sit in the chair, my foot's fine. If I go to bed and lie flat, I get pain. And what happens here, that means that the circulation is so bad, if I sit in the chair with the foot hanging down, there's a certain amount of blood flow that's going to get there based on gravity. If I lie flat, you take away, for lack of a better term, the gravitational blood flow. And so the patients get pain based on ischemia. Non-healing wounds is another, this is commonly seen in diabetics, or the other thing is someone that has occlusive disease, they get some kind of injury to the foot, they get bit by an insect, grandson drops their train on the foot, causes a little sore, it won't heal. Diabetic cuts their toenails, don't see it cut into the flesh, it doesn't heal and it gets progressively worse. That's considered a non-healing wound, and a lot of them are not healing based on poor circulation. Or frank gangrene of a toe or a foot. So how do we diagnose this? Well, we'll go back to our Doppler test. There's the segmental pressures. We talked about that, measuring the pressure in the arm and the legs and getting a series of pressures up and down the leg. If you look at the waveform here to the left of the screen, it's markedly flattened compared to that one. This is the tech doing the pressures. And this slide here sort of depicts what the problem is. Narrowing in the artery, and actually a little bit of thrombus starting to form. However, what I like to do is I like to order arterial duplex imaging or arterial duplex scan here. And the reason being is that our techs, they take that ultrasound probe, they go up and down the leg, and you remember we talked about in the carotid arteries, we get that high velocity. Well, the same thing can occur in the leg, and what the duplex scan allows me, it could tell me if it's the artery here in the thigh called the superficial femoral artery, it will tell me the velocity is elevated here, and I can plan my treatment to know that there's a problem there in the leg. The segmental pressures will not necessarily tell me that. And so we talked about that high velocity. You can't see the numbers there, but you see how high that peak is. In fact, it's so high it's being cut off by the top of the scale. They can't get it high. That's a problem. How do we diagnose arterial disease? Well, the CT angiograms become a more popular, or what we call the standard arteriogram. And you can see this is what the normal artery looks like. This is an artery where there's a blockage in the iliac artery. As you see, there's a bifurcation, iliac artery on each side, good blood flow. You look at this middle side, there's no blood flow on the right, there's some blood flow on the left. Then if we look at this one, on the right side, the artery shuts off. That's a blockage in the superficial femoral artery where it's open. So the angiogram gives us all this information. So the good thing about standard arteriograms, though, versus the CT scan, is that at the time of the arteriogram, we can fix things, and that's called an angioplasty. You all guys, everyone's seen this is an arteriogram. We access the groin, the catheter's placed up. We inject this contrast. The contrast follows the path of blood flow and outlines the artery. Here, this is a popliteal artery. There's a critical narrowing there. And then following that, a wire balloon's placed through there, and it's angioplasty, and it's much better. So we just briefly hit on that. Treatment can be minimally invasive, done in our angiogram suite. This is the result. This is how a balloon angioplasty works. We have a plaque, we get a wire through that plaque, we take a balloon over that wire, we inflate that balloon, inflate that narrowing. Now sometimes we don't get necessarily the good result that we want, so what we do is we'll take a stent, for lack of a better term, that stent will sort of work as a scaffold and keep the artery open and keep it from collapsing down again. And it compresses the plaque. Surgical treatments for occlusive disease include endarterectomy, bypasses in the leg, either femoral to popliteal bypass graft, or we use the term fem-distal bypass graft to encompass all these arteries that we go to, the anterior tibial, posterior tibial, and peroneal artery. Sometimes we'll do femoral bypass going from one groin to the next. I think we have one coming up Monday. Axial femoral bypass from the axillary artery down to the femoral arteries. And sometimes all of them, any of these operations may encompass a femoral endarterectomy to clean the artery out, because a lot of times the arteries will be so diseased that you cannot sew to them. So this is the endarterectomy in the femoral. Just like in the carotid, the artery is exposed, the plaque's teased out, and we sewed up with a patch. This is the femoral to popliteal bypass graft. The popliteal artery being at the knee or below. So we take a vein graft or plastic, either one, we sew it in above the blockage, tunnel it, and then sew it in below the blockage. And this is what it will look like afterwards. So this is the femoral artery in the groin, this is the bypass graft, and it's sewn either to a tibial artery, to the popliteal artery, above or below the knee. Again, this is how the bypass graft works. The femoral artery, blood comes out of the bypass down to fill the artery here. And all this segment is blocked. So now the other options are, for patients that are too sick for certain operations, we'll use the AX-FEM, or expose the artery here below the clavicle, sew a bypass graft here, tunnel it under the skin, and sew it into the groin. This is for someone that's got an aortic issue, but they're too sick for an open aortic procedure. So other options, patients that may have iliac disease, we do, as opposed to doing aorta femoral. If one iliac is open and looking good, we'll go femoral to femoral bypass graft. And that's what this looks like here on CT angiogram. So post-op management in these patients, one, as most of our patients, antibiotics, pressors are always available, antihypertensives. They all get antiplatelets post-op, pain medicine, anti-nausea medication, Important things as we talked about: wound girth, EKG, arterial blood gas. If the patient's acidotic, that's a concern because the acidosis is going to suggest that there's some compromised blood flow to some tissue. We'll check the troponins, the Chem7, the PT-PTT, urine output, and we'll check neural function. So complications of lower extremity revascularization are going to be myocardial infarction, cerebral vascular accident, gangrene if the graft fails, arterial ischemia if the graft is failing. This can be seen post, we talked about the atheromatous emboli and so forth and the aneurysm repair. Well, that can occur with lower extremity bypass graft. See the difference in the color of these two legs. Hematoma within the wound, graft failure, meaning the graft is shut down. And sometimes, unfortunately, when the graft is sewn to the artery, it gives loose and causes a hematoma, and they bleed pretty briskly, and we call that graft blowout. Any questions?
Where do you get the donor graft?
Okay, good question. The question is, where does the donor graft come from? And that, two things. I like to use veins, so if the patient has you'll see on a lot of my patients, I order what's called vein mapping. So I will image the saphenous vein in the leg, and then if the vein is good, I'll take the saphenous vein out and use it. If the vein's not good, then we'll use grafts. They're called Gore-Tex, so the scientific name is PTFE, polytetrafluoroethylene. And we sew it in above and below. That's in the leg. If it's in the belly, we use what's called Dacron. And almost 100% in the belly, we're going to be using synthetic graft just because of the fact that the aorta is large caliber, so you'll never find any autogenous, meaning the person's own tissue large enough to accommodate blood flow. Have you guys had enough? Good question. The question was, who asked? How long do the procedures take? So it's going to vary. A lot depends on, one, the patient's size, the amount of disease, because if it's straightforward, you don't have to do endarterectomy. You go in, expose the artery, sew in. It's much faster. It doesn't take as long. It's not as in detail. Unfortunately, I get all these patients, none are straightforward. They're always complicated, so it takes longer. So like for a fem-pop bypass, femoral to popliteal bypass graft, about 3 hours. Aorta fem, about 2 to 3 hours. Endovascular aneurysm repair, about 1.5 hours, 2 hours. My carotids, no matter how difficult or how hard, they always take 2 hours to do.
What is the average blood loss?
The question is, what is the average blood loss? Who asked that? About 600 cc's open. Endovascular repair, about 100.
What about the time to stay in the ICU to go?
So for endovascular repair, they go home within 36 hours. They stay in the ICU overnight. For open aneurysm repair, they're probably in the ICU for about 10 days. They're in the hospital for about 5 to 6 days. For leg bypasses, a lot is patient dependent. Some patients, you operate on them, you go in there the next one, and they're dressed, ready to go. Some of them, you could blow the bed up and you couldn't get them out of there. So, a lot of it is patient dependent. But standardly for, let's say for instance, a fem-pop bypass graft, I would keep patients usually for about 2 to 3 days. Carotids go home the next day generally, unless maybe they're having some swallowing difficulty. Maybe headache is another thing that they may get that may keep them there another day. For stenting, anything that's done with stent, they almost invariably will go home the next day. Even some, let's say for instance, we put a stent and let's say I did it at 8 o'clock this morning. Sometimes I've been liberal enough, if I go back and see that patient, which I'll generally see about 6 or 7, if they're fine, I'll let them go home that day. I'm sorry, who asked the question? Great, what was the question?
Everyone goes on anticoagulation.
Good question. The question is, does everyone go on anticoagulation? Most patients will not go on anticoagulation. Most patients will go on some form of antiplatelets. So like carotids go on Plavix or aspirin, or both sometimes, depends if they have previous heart stents. Lower extremity bypasses will go on Plavix most of the time, at least for 3 months. Open aortas, I don't use much of anything. In the vascular repairs, I use Plavix.